Thanks so much for joining us tonight. Um, my name is Dr. Punita Tandon. I'm a professor of medicine and co-director of the Cirrhosis Care Clinic and a transplant liver specialist at the University of Alberta. And I'm one of the medical directors of lifelong learning in the physician learning program. Emily, could you share the awesome, thank you. So we're presenting today from Edmonton, Alberta, just to give a territory acknowledgement, and the traditional land in which we are located is Treaty 6 territory. So we acknowledge we're on the traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. So the learning objectives today, this is the management of alcohol use disorder primary care workshop series, and today's topic is alcohol use 101, which was our first topic, but is our last topic of this series. And two excellent speakers are going to go through explaining the biological process of alcohol use disorder as brain disease, reviewing existing literature on healthcare practitioner attitudes towards patients with AUD, describe the multi-system consequences of AUD, and the management of patients with alcohol withdrawal and anything new in that space. So with that, this is the agenda. I'll be handing it over to our speakers in a sec. Let me just introduce you to them. Dr. Monty Ghosh, who's an internist, addiction specialist, and assistant clinical professor at the U of C and the U of A. And he works with multiple community-based non-for-profit organizations to provide support for marginalized populations. And he's heavily involved with provincial policy building around alcohol and other drug use in Alberta, clinical and health systems research and implementation science provincially and nationally. His name is pretty much everywhere that has to do with this topic. Dr. Jessica Kirkwood has been a family physician at Radius Community Health and Healing since 2012, and she provides primary care to patients dealing with homelessness, mental illness, and substance use disorders. She's also an assistant professor with the U of A and a member of the peer team, and you'll be able to tell during the presentation she's absolutely passionate about helping educate healthcare providers and learners to care for marginalized patients in an empathetic and evidence-based way. So with that, I will hand it over, Monty and Jessica, to you, and thank you so much for guiding us through the next 50 minutes.
All right, thanks for having us here. I think Jessica and myself are pretty informal, and we're just gonna totally like go back and forth on this, and you've got like two hosts for the price of one, I guess. And so
it's a really deal. Like, who doesn't like a deal?
Do this. And so, hey, everybody, glad to be here. As of this very moment, I moved from Treaty 6 territory to Treaty 7 territory. I'm in Airdrie, Alberta. So really glad to be here today, and grateful again to talk to you guys. And then maybe Jessica, I don't know if you want to do a quick blurb.
Well, yeah, I would just say thank you so much for having me. I do apologize if you had signed up for this a few weeks ago. It would have been a different presentation because I had gastro, and I don't think anyone would have wanted to have seen me in the state I was in. So the change to tonight, that was 100% on me, and I thank the organizers and you as well for sticking it in to come. And that's why the order's a bit flipped, that you're getting 101 at the end of a 3, so it does say session 1, but yeah, anyways, much happier to be here today. Feeling a lot better. So but yeah, we'll just get started, but please, at any point, I'm going to open up the Q&A window here and let me know, is that blocking anything? Zoom was doing some weird stuff. You just see the nice presentation screen, right?
Yeah, very good.
Okay, good. I'll have the questions up there though that we can kind of tackle as we go, and then we'll have time for them as well. And yeah, first we'd like to know just a little bit about you, I think, in terms of if you feel comfortable sharing in the chat where you're joining us from, what's your role in taking care of patients, or yeah, anything you feel, oh my goodness, too fast there, anything you feel like sharing. I'm also going to open up the chat.
Anybody from outside of Alberta by chance?
Yeah, we could do a little hand thing. Do you know what? I was excited to learn about the coffee cup feature tonight in that intro. I had no idea there was a little coffee cup that you could put up when you step away. Did everyone else know this? There's lots of things that I don't know, but yeah, if you feel comfortable, maybe in the chat, or throw up your little hand to say if you're from outside of Alberta, let's say.
All right.
Oh, here we go. Fantastic family doctor from Calgary. Thank you for joining us.
Thanks for being
Oh,
here.
Sarah, behavioral health consultant with the Primary Care Network. That's fantastic. We've had two fantastic behavioral health consultants at the clinic I work at. Oh yeah, and if you were like, oh hey, I thought that lady worked at the Boyle Macaulay Health Center, I still work at that health center. We just changed our name to the Radius Community Health and Healing. So people might be like, oh, she got fired.
Oh,
Nah, not yet. They didn't
really?
get rid of me. Keely at RN and Airdrie, that's fantastic.
And Alberta, amazing. Red Deer.
Oh, Nova
Yep.
Scotia. Oh, Debbie, thanks for joining us. We're so excited. We were just talking about beautiful Halifax and lobster rolls, actually, prior to the the session starting. And from Hannah, wonderful. Awesome. Thank you so much, everyone. All
So, you
right.
know what? I'm amazed by the number of non-physicians here, which is fantastic. That's exactly what we need. So we're gonna make sure that we're gonna, touch on some of those other paramedicine pieces here today. So that'll be awesome.
Yeah, absolutely. Okay. Yeah, so what we're going to try to do, we did this before and I think it worked, so we're doing it again, is we're going to go through two cases kind of at the same time. And we're going to introduce you to two different patients that both stem from people that we've met professionally in our careers and that we've based off of patients that we've seen before. And to just kind of highlight the many different ways that patients can present within this umbrella of alcohol use disorder. So I'll let you go ahead, Monty, and introduce us to Eric.
That's good. So Eric is your 31-year-old male who presents by private vehicle with his roommate. So his roommate kind of brought him in, and he was feeling horrible, so sick that he's never experienced this type of sickness before. He was a bit vague with the symptoms. He was saying he was feeling shaky, nervous, and had the sense that he's very, very just off. Was having palpitations, very sweaty, and has a slight tinge of nausea, which is really holding him back from sharing more of a story with you.
Yeah, these are the people that are like super chatty when they're coming in. And so I'm going to introduce you to Melanie, who is a 42-year-old woman who's been staying at different shelters in Edmonton. And you meet her in what would be a medical dorm, perhaps. So sometimes that can be a bit of a shelter setting where medical assistance is provided. I actually based this off of the work that I did at the isolation facility that we had set up in Edmonton in a few locations over COVID, because we would have a lot of patients that would come in to stay with us and then would either present in alcohol withdrawal or would develop alcohol withdrawal over the time that they were with us, especially if they were having to isolate due to COVID. But this Melanie in this case becomes because she's been having some respiratory symptoms. And she said she feels fine. She feels fine. She doesn't really want to talk to you. She just wants to rest. So you're not getting much out of Melanie.
So what's going on with Eric? When you take a look at him, you do your basic vitals. He has an elevated heart rate. His respirate's a bit elevated as well. His BP is really high, and he's also has a low fever. Very anxious, skin is diaphoretic, and he's flush. When you do a quick physical exam on him, his ear, nose, and throat areas were fine. Lungs had no adventitious sounds. He was tachycardic, but he was in sinus tach. No murmurs, rubs, or gallops. And then his abdomen is soft with normal bowel sounds. He was non-tender, non-guarding to rebound. So he felt otherwise well. The rest of his extremities looked good. Neurological exam was fine. He did have a bit of a tremor, which got progressively worse as time went on, and no sensory deficits.
And there's going to be no mystery about the internist versus myself as a family doc, because with things with Melanie, not to say that family doctors can't do excellent physical exams, we very much can, but in this case, again, Melanie really wasn't wanting to engage at all. So she's got a normal heart rate of 78, her rest rate was 14, blood pressure is 120/73, her temps 36.8, and she just seems really anxious and kind of irritable. Other than that, she did not want a physical exam at all. She barely wanted to be in the room. So yeah. So that's kind of our intro to our patients, what they've come in with, and some really first basic information. And so then we're going to ask our audience, what more would you want to know about our two patients? Where are we going with this? And I think I always love these where it's like, what could it be when it's, alcohol use disorder 101 or alcohol withdrawal, but what kind of things maybe when we're looking at these presentations would you want to be knowing about our two patients here? We'll let you pop those in the chat if you feel so inclined. Or you can raise your hand and unmute. That's fine too. Looks like Monty's going for the chat.
Yeah. I was looking at the chat. Hey, I was like looking. I'm like, I can't see anything there. But oh, did someone put something in there? I think someone. Yeah, let's. Just...
Yes, Dr. Tandon, excellent work. How about an alcohol history? And that may not be right, which you'd lead off with, right? I mean, yeah, I think that as we well know, there you go, Mary. What brought you in to see us, right? That would be maybe a good place to go to as well. If someone's presenting to a detox center, then that's opening up that conversation in terms of substance use comes much easier, right? I think we all know what they're there for, but in Melanie's case, she's just there because she was having some respiratory symptoms and really didn't feel like addressing that, whether or not he felt that that was an issue.
And same with Eric too. Eric just presented to the ER. I think he was in the ER. Did we say he was in the ER? I think we
Where
said,
was Eric? Did I go back?
So we don't necessarily know, but I love my basic internal
Yeah.
medicine stuff. So we get a past medical history. We'll determine if he has any allergies, of course, which is important. What medications he's on. The other thing that I think is very important is the social history. For me, that's so crucial in terms of overall wellness. I'm sure it is for Melanie as well. But like for Eric, I want to know what's his housing situation like. What's his what substances is he taking? Is he taking any substances? I think these questions are very pertinent, and I find that people often minimize what's going on with them, and they know, but they don't want to say it.
I was just thinking that I'll come, I'll come out like gangbusters, ask a bunch of things, and finally, if I'm really having trouble, I'll be like, well, what do you think's going on? And they're like, well, I'm super dope sick, or I'm in a ton of withdrawals, and I'll go, okay, like, let's get to that. So sometimes I'll go there earlier than after. What do you think might be going on that you feel so terrible? So yeah. Okay, well, let's learn a little bit more about, and has this happened before? Awesome. Let's learn a little bit more about our patients then.
Yeah, so past medical history-wise, states he's otherwise healthy and A-OK. Mental health, which is a key component to actually their overall substance use wellness, which I think we'll touch on this, or it might be coming in another presentation. But he states he feels anxious every now and then and feels lonely, but no major issues. In terms of medications, he has none, allergies, none. He works in IT, lives with his roommate in downtown flat, smokes occasionally with alcohol. But when asked about drinking, he states he doesn't drink anymore. Another common thing we often hear. And then grandfather and uncle had significant alcohol concerns in the past, but they're well, and it's not an issue for them. And that's another important factor, is that we do know that substance use can be genetic, addiction can be genetic. So it's important to sort of elucidate that, because it increases the probability that there could be something going on here. And it's something important to address in terms of the overall wellness. I find that often often we think of substance use as being a behavioral moral concern. And when I frame it as it's a genetic concern, it becomes more biological, it becomes more of a disease process, which it actually really is. Mm-hmm. And so it medicalizes it, makes it less of a moral failing and less of a personal choice. And it frames the discussion a different way.
Yeah, I like that a lot. Absolutely not a moral problem at all. So Melanie comes in and we get a bit more information. She says she has a liver problem, not much more than that. Really doesn't want to talk about her mental health. She's also not on any meds, doesn't have any allergies. She is currently homeless or unhoused, and she smokes half a pack of cigarettes a day, and she's really not too sure about her family history. So that liver problem might clue you into something. You might be a little bit concerned about that, but you didn't get too much information there. All right, carrying on with Eric, what do we find out now?
So in terms of what else we can do right now, so fortunately here in Alberta, we have neck care. So you go into neck care and you see that he was last in the emergency department Calgary Stampede, after being found on someone's lawn with his alcohol level being at 0.6. Not the highest I've seen, by the way. And when pressed further, he states he quit one day ago because his girlfriend had been asking him to quit for years. Often a common story, they'll tell me that they're done drinking, and you're like, oh, when did you quit? And it's like, oh, it was 7 hours ago. Like, okay, fair enough. And states he was drinking a Mickey of vodka a day.
Yeah. And so, yeah, so if we have people from all over the country, and Mickey for us is like the little guy you put on there, the 375 mils. But yeah, I forget because I went to school at Nova Scotia, and so all the names were mixed up. And absolutely, Netcare, really, we are so lucky to have that within our province. You can know so much about a person before you even see them in terms of what other things they've presented with to hospital and things like that. Yeah, so what we get to talking to Melanie a little bit more, and she shows that actually she does drink alcohol and usually has about 26 ounces of vodka daily. And she has done that for about 5 years. Her last drink was a day or two ago. And we saw a ton of that again at the isolation facility when people came in because they were sick. Maybe they, depending if they had access to money or not, there could be a lot of barriers to being able to access quite a large amount of alcohol regularly on a daily basis. And so people might come in quite sick. She doesn't use any other substances. And again, she was told by a doctor a few years ago that she had scarring in her liver and that she might die if she doesn't stop drinking. And unfortunately, I've seen that on many a consult letter for my patients. She was admitted to hospital about 6 months ago because she was vomiting blood and she was supposed to be taking her stomach pill, but she had lost her most recent prescription and she doesn't have a family doctor or a doctor that she can get refills from. So yeah, big red flags there that are coming up, things that we would be concerned about as she was coming to stay with us at our medical shelter or in our emerge or wherever we might be. Well, yeah. Let's carry on. Oh yeah, and then we had this little kind of, oh yeah, because I talk about different sizes and different things like that, right? So we did bring up the image for the kind of the standard for one drink a day, right, Monty? Because I know that I'm sure you get lots of variations. I certainly hear lots of variations in terms of a beer. Well, is it, is it a can of beer like a 341 ml can, or is it a big bear or a huge bottle, or all these different things? And so even the idea that wine is a 5-ounce glass, right? And many places, a 9-ounce, people would have a couple 9-ounce glasses and consider that to be 2 glasses of wine, right? But that's actually quite more when we're talking about units of alcohol.
So, and things are shifting a bit too. I mean, these are some of the classic definitions, but I've seen a lot of people define a single drink as being 1 ounce. I mean, that's what we do at bars, right? A bar, you get a drink of something, you get a 1 ounce of it. Right. And then beer is like 8 ounces is sometimes considered a drink as well. These are the official numbers, so definitely follow these, but there is some variation in this for sure.
Yeah, totally. All right, so moving on to some investigations we've got for our friend Eric.
Yeah, so with Eric, we've seen he's got a slightly elevated white count. His hemoglobin is slightly low. His MCV is interestingly 104. Platelet count is slightly low too, but not the worst. He's hypokalemic with the potassium 2.9, and the rest of his labs look reasonably good. I don't think his calcium's 9. I don't know where that's coming from, but that might have been a mistake there. But
you just threw that in there to see if you're paying attention.
Right. But his AST and ALT are a bit elevated as well. As you can see that there's a bit of a ratio there between his AST to his ALT, almost a 2 to 1. And he also has an elevated GGT, which is also very important, which we'll talk about in just a bit. His albumin is also low at 31. And then his TPLA is actually okay at 15. Serum alcohol was negative, urine tox screen was negative, and the urinalysis trace protein was otherwise normal. But we did do an ECG on him, and he did show up as sinus tach.
Monty, I don't know are we going to get to like lab results later, or should we just be talking a little bit about highlighting them here? Because I
can't remember either. Let's just highlight them here right now.
Let's do that. Yeah, I think so.
So the big thing to note here is that the MCV is elevated at 104. One of the big things here. And it's just because we do know that with alcohol, there's less thiamine folate absorption in the gut, and they do have deficiencies. And so with the folate, especially in this particular situation, we might have an elevated MCV. On top of that, the ACT-ALT value is really important. As a 2 to 1 ratio, it's highly predictive of alcohol use disorder. When you get to 3 to 1 to 4 to 1, the specificity is really high, and that's almost indicative. Whereas with the 2 to 1 ratio, it's not as necessarily as indicative, but it is. I mean, it is indicative, but it's not as specific as it is with the higher numbers. And then the GGT is also very indicative of recent alcohol use within the last few days. And so the GGT being at 663 is fairly high. So again, it's very indicative that he's been drinking. It's one of our indicators. A better marker is is carbohydrate deficient transferrin. We don't really use that here in Alberta, but that gives us more of a bigger window of 2 weeks to 3 weeks of knowing if they've been drinking or not. As albumin is low, again, kind of pointing to a sort of a nutritional deficiency or potentially liver issues and concerns. But fortunately, we can see here that his INR is looking good there. So less likely of it being a liver issue than more of a dietary issue. Which we often see as well. We see clients who will rather spend money on booze and spend money on proper food. So that comes up a lot as well. So yeah, all really important things to sort of point out here. Yeah, I'll pass it over to you.
Okay, sounds good. Yeah, I cheated. I don't think we had a slide to talk about that, so I'm glad we talked about it now. And then in terms of Melanie, why won't it advance? Come on, buddy. There we go. She didn't want any blood work, and I kind of cringe at my wording here. Resisted. I don't like that. I would change that slide if I would write it again. But I think that the important thing to note is so many of our patients, especially those that are marginalized or racialized groups, have received medical trauma when they've gone into different places. And so just to remind ourselves that those people that really aren't wanting to engage in care, it's not because they don't care about their health. It's not because, it could be because that they're quite scared. It could be because she's been poked and prodded a bunch of times and she's received a lot of judgment depending on where she's been and how she's been treated. And you can still completely manage patients with some pretty concerning things in their history that are presenting in withdrawal without needing to know all their labs, right? We just need to know kind of what's going on right now, and then we can proceed. So you may not have all the answers, but we can still help someone. So yeah, we're going to move on and say, hey, is this person in withdrawal? And how would we determine that if somebody's coming in? We've obviously got a lot of information in one case, maybe less in another. So, what kind of tools could we use to figure that out? And so, love our DSM criteria. They're just, always right there. But when we do talk about gold standards in terms of diagnosing things, certainly we're looking for the cessation of alcohol use. That would be a fundamental component of alcohol withdrawal. And then when we're looking at other symptoms that people may present with, we certainly have quite a few of those. And so I'll just click all of these up, and then we can kind of see, am I going to go one more? Yes, I am. That would be a bad one. But when we look at Eric, for example, he's tachycardic. I can't remember if we said if he was tremulous. He was saying that he was super duper sick. He was feeling really anxious. Melanie wasn't demonstrating as many maybe objective signs in terms of like her pulse or different things like that, but she certainly was really irritable, was really anxious. And then we would want to be asking a few more things in terms of those visual, tactile, or auditory hallucinations, and certainly wanting to know if someone's had seizures in the past, or if even they've had a seizure maybe before presenting to your care. I don't know what else you'd like to add in there, Monty.
Yeah, so I think the big thing here is that hyperactivity piece, and that's sort of the key. Is all of these, well, minus the insomnia, plus the insomnia, I should say. You see a lot of hyperactivity in the sense that we know that, and the way I like to sort of explain it is that when people drink a lot, they really activate the GABAergic system. And the GABAergic system, as we all, as you may know, some of you may know, is that it's very sedating. So when we keep drinking alcohol more and more and more, we're very sedated. We're very, we fall asleep if we don't drink alcohol enough. But then as we drink over time and we keep on maintaining that level of alcohol in our system, the body compensates for that. It realizes that we're drinking ourselves to sedation. So let's try to stay awake. Let's try to avoid this. And so you see an upregulation of this molecule called glutamate. It's a neurotransmitter. And that glutamate molecule is very hyperactive. So it keeps us awake, keeps us rolling, keeps us moving as we continue to drink alcohol. So after a few months of just drinking constant amounts of alcohol, we sort of have this counterbalance in our system to keep us really normal, if you may. It keeps us in homeostasis. But then if you stop drinking alcohol, you stop stimulating that sedative activity that you often see, the GABAergic system. So now all of a sudden you have the exact opposite problem. You've got too much molecules in your brain, too many neurotransmitters that are very hyperactive. And so guess what happens now? You're super hyperactive. That's where you get all of these symptoms. And so you've lost that that ability to take care of that, sort of you've lost that sedation activity that alcohol provides. And so the way we sort of counterbalance that is we give you more sedatives in the the interim, which we'll talk about in just a bit, medications. That's kind of it in a nutshell. And that's why you see these symptoms. I hope that was helpful. I hope that people, that it clears things up as to why we have these types of this sort of manifestation.
Yeah, sometimes it doesn't make sense. And I think that's a great way to describe it. That actually, I don't know that you did last time, so I appreciate that. Thank you. I didn't realize that on the next slide, I was actually going to be working through kind of what different symptoms Melanie had, but I don't know why I said that her pulse was greater than 100, but it wasn't. But she certainly had that autonomic hyperactivity, anxiety, and my guess would be if she's normally drinking 26 ounces of alcohol a day and she hasn't had anything for 1 to 2 days, she's going to have a tremor, and she's probably not going to feel 100%. So patients can be incredibly stoic and can hide a lot of things, and that you really do need to make sure that you're asking the right questions so that you're identifying if this is somebody who's at risk of maybe some bad complications from withdrawal. Oh, Linda managed to draw, and I don't know how. That was neato. Is it going to stay or will it go? Let's see. Oh, I don't know. Okay. Well, anyways, there's so many neat features in Zoom. I'm so excited. Yeah, so we'll move on to the validated scores to look at the degree of withdrawal that people are in. And I think that CWA AR scales are probably something that you may have heard about, but if you haven't before, it's an assessment that you can use to determine how much withdrawal somebody's in. So it's a 10-item rating system. And basically, when you're going through, obviously, if someone scores 0, that's very, very low, and meaning that they're probably not in very much withdrawal. And then as you carry on, anything above 8 probably indicates that medications would be necessary. Here, I'll just move ahead. The different things that the CWA score looks at are kind of listed here, and certainly some of the things that we had talked about. This can also be used to help guide medication as you're moving along through your assessment. And so we'll talk about that, how you can periodically assess how much withdrawal someone's in using this scale. I don't know if there's anything more you wanted to add there, Monty? Or if we want to
my big thing, like when I try to explain this, is that there's different ways of addressing withdrawal. And 90% of people, if they don't have cirrhosis in particular, will actually do fine without any medications. Not that we want that to happen, and not that we don't want to give medications, because we should. It's the 10% of people that we're really, really worried about. And so there's 3 sort of main strategies to sort of taking care of withdrawal symptoms. So one is that you front load patients with benzos, which we'll talk about in just a bit. And because most of the most severe symptoms of alcohol withdrawal happen within the first 72 hours, whether it's the first 24 hours for delirium tremens or the first 72 hours for actual withdrawal seizures, for example, we see most of those symptoms within the first 72 hours. The other way to approach this is through the CWA, which is like basically you measure them for symptoms and you provide them medications as you see the symptoms progress. And so that way you don't give them too many medications, but you don't give them too little. The third strategy is a scheduled dose of medications. And so you just provide them with set schedule. In acute care, we're starting to do this more and more. At least I do this with my patients. I give them a scheduled dose, and it saves, in terms of, in some respects, it saves people from getting too many CWA scores. It saves nursing supports, but it's not always the best strategy for everyone. And so, I mean, I think a lot of us get stuck on CWA because it's what we are trained with clinically. I remember when I was a resident, we were like, just do a CWA. But there's multiple different strategies out there. I think what's the term I'm trying to think of? Pearl is that we can actually front load. And that's a really cool strategy. Is really, focus on the first 72 hours and really focus on having benzos out there up front right off the bat. And if you want to do a high dose of benzos, start off with a high dose of benzos and then go down, as opposed to starting low and going up. So hopefully that's some clinical pearls for you guys to use.
Yeah, absolutely. So when we look at our 2 cases here, we'll just say that, basically we did a CWA on our patients in this case, and Eric was at a 10 and Melanie was at about a 23. So now what should we do? And we've already touched on that. Oh, why does this 8 ball appear? That was like, that meant something to you, right?
Yeah, 8 ball is just that if you have a CWA score of 8 or more,
Yeah, there you
you
go.
start medications.
That's right. I'm like, what is this random 8 ball doing here? There we go.
Your food.
And so, so as we had mentioned, benzodiazepines are the most commonly used medication when we're looking at treating alcohol withdrawal, and that gabapentin can also be used in acute care as well as an anti-craving medication. And I'm pretty sure that one of our previous sessions talked on anti-craving medications that you can use, but gabapentin is certainly one of those. Some other medications that you're wanting to think of would be that vitamin replacement. Monty, do you want to take us through this, or do you want me to?
Yeah, go for it. It's pretty
Sure.
straightforward.
Yeah, pretty straightforward. So again, if you're able to give thiamine IV, that's great. If not, IM or even orally is good, and the doses are there. And you can go on about why we're doing this prior to glucose if you want. Again, this isn't my area. I'm doing the family medicine stuff, but I also want to remember to give folate as well as a multivitamin for many reasons, and one of which Monty touched on already is that often patients can come in quite nutritionally depleted when we see them, and there can be many consequences with that. Yeah.
Oh yeah, I should probably mention the glucose piece. Glad we put that in there. So basically you wanted the glucose before the thiamine just because if you give thiamine right off the bat, it often causes a depletion of glucose as it gets it's a cofactor for metabolism. And so then what we often see here is that we see a huge depletion of glucose, people become hypoglycemic. So yeah.
Can really muddy the waters and change the clinical picture. And right, you might be seeing that your patient's becoming sedated or drowsy, and you think that might be the medications, but also they could be hypoglycemic, and that's not so good, right? Totally. All right, excellent. So we talked a little bit, or we wanted to talk a little bit about the different levels of detox. And this really, really depends on where you're working and what you might have access to. Yeah, a few things that I've really, so I'm a family doctor, as mentioned previously. I think that COVID was not fun, let's be honest, but there was lots of things that I learned to be able to do that I wouldn't have tried otherwise, in terms of managing patients in withdrawal at home, in, like I say, in isolation facilities, which were sometimes like a cot in a hall or a hotel room when we had areas set up. I also really, really leaned heavily upon my team. And so in Edmonton, we're really lucky to have what's called a community paramedic response team. And that's an EMS team that can go to your patients, do a full assessment, and provide many, many things that they would need in hospital level care in terms of IV and IV administered drugs, doing labs. And they can do all that and call you and kind of get orders from you. And so prior to COVID, I have to be honest, I wasn't super creative, because I would mostly tell people that could access a detox center that they needed to go to one of like a standing detox center, which is your traditional, where you can go get a bed and receive medical treatment there at varying levels. And since then, I've really, really broadened my approach, because we are facing a crisis. We know that people can wait a very, very long time to get into detox. That can be dangerous. We know that our emerges are really overwhelmed. And so I have certainly broadened my approach to try to manage things, if I can safely manage them as an outpatient. So yeah, I don't know if you have much more to add in terms of all the various places patients can detox, but that's my spiel.
I think like for, community paramedics actually exist all around the province now, which is amazing. So they exist
Fantastic.
all seven cities and in some rural areas. So definitely utilize them if you can. I think there's tons of detox facilities throughout the province now compared to before. You might have to go to your local jurisdiction and directory to sort of figure out where is what. And I think I encourage you guys to do that. And HS has a really good resource guide on the website around which detox facilities are located where, and you can just type in your postal code. You can find what's close to you.
Yeah, great. So what was your plan for Eric? What did you do for him?
Yeah, so it looks like here I'm giving him diazepam every 4 hours, the 10 milligrams while he's awake, and then some PRN lorazepam if his CWA score is greater than 10, and then QID for 24 hours thereafter, 5 milligrams QID, then 2 milligrams. So it's a bit of a taper afterwards. And then the other alternative would be lorazepam 2 milligrams every 1 hour for C-bars greater than 8, then give every 4 hours PRN, and then decrease to 1 milligrams. I made a mistake here with the, I'm just thinking about this. It's been a while since I thought about the glucose and thiamine issue. It is a coenzyme, and I think it's because it causes lactic acidosis. That's the reason why we try to avoid it. We try to give it beforehand. Because if thymeine's not there as a coenzyme and you give just glucose, you get more acid production because the cells don't enter the Krebs cycle. So apologies on my end. Thank God that mixed up. So sorry.
I wasn't going to correct you. You could say anything and I believe you. So either way.
Yeah, so correction there. But yeah, these are sort of two different protocols you can use. And then
And you mentioned when we originally put this together and it was accredited, I don't think we had looked at that kind of front loading schedule. So maybe what would that look like if you wanted to do that for Eric?
Yeah, like with Eric, I would probably give 20 milligrams right off the bat and then give maybe 10 milligrams every 4 hours thereafter. So really front load those benzos, give him a heavy dose. And now there's that risk of making him over sedated. There's that fear, but really that is a strategy that a lot of people use, a lot of jurisdictions use to really get things under control. And the thought process is that if you really put things up front, you lessen the risk of them having effects later on down the road. And so there's this. Yeah, I think that's maybe the simplest way to put it. But yeah, there's this thought process that you can actually, by front loading, just really decrease the risk because there's a sort of kindling effect, if you may, with seizures that you kind of precipitate if you don't really have things up front and off the get go.
That's interesting. And I do like the idea of maybe a structured scale that's not requiring a CWA, not requiring someone to have to do all that when we know how, overburdened and overworked many of our staff are. If it isn't really necessary and it's not maybe going to change outcomes, or if it's not a big safety concern, then that would be, I think, really, really quite ideal. I remember at times we would have, 10 patients in our isolation facility, but other times we'd have 80 and our nursing numbers didn't change. So you can imagine that, depending on how many patients we had, we really needed to be careful about how much we were overburdening our team members. So yeah. Now, one thing about Melanie is she mentioned, liver scarring. And so we can interpret that as the fact that she was probably diagnosed with cirrhosis. And we would be really cautious about using a longer acting benzodiazepine, such as diazepam. We would want to lean more towards something shorter acting so that those metabolites didn't build up in her system, cause excess sedation and other issues. And so we would use more of a lorazepam or even oxazepam, which are both quite short acting benzos to manage her withdrawal. So yeah. Moving on. Let's learn a little bit more about what happened with Eric. Maybe he's feeling a little bit more comfortable and he can talk about this a bit more.
Yeah, so now Eric is feeling a bit better. He's less agitated. And so we've given him his benzos. And so just talk to a bit more. He states that he's never passed out or blacked out. And he states he's not vomited recently and feels otherwise well. Girlfriend arrives and provides further information. He's been drinking since the start of their relationship 5 years ago. He usually binge drank for the first few years in the relationship, but things worsened during the pandemic. And we actually saw some data that things were much, much worse during the pandemic. And while at home, and I suddenly began to drink on a daily basis. Is up to 1 bottle of vodka a day. Yeah, we definitely saw a ton of that for sure. And with all substances, but alcohol was certainly one. So for Melanie, this is a nice opportunity that if she doesn't access care very much, we could provide her with some things like restarting her pantoprazole. It sounds like that would probably be ideal with this history of a GI bleed. Maybe connecting with some supports for medication coverage, financial supports, potentially housing options, depending on what you have. I know that I have a really full panel, but every time I worked an isolation facility shift, I would leave with a new patient because I would meet someone that didn't have a
family doctor, and I just could not possibly imagine them continuing. So I'd say, like, come see me on Tuesday, and I'd be like, oh, I know my patients always complain it's hard to get in to see me, but we just have such a high need for patients to connect with primary care. Maybe talking about contraception, if that's something that she wants to talk about at that point in time, or offering things like sexually transmitted or bloodborne illness screening, seeing if she needs any sort of vaccines to make sure that her healthcare is up to date. Because again, we're just going to use this opportunity to manage whatever we can. And then if she is interested in either outpatient addiction supports, looking at speaking with a counselor or going to meetings or things like that, or if she was interested in inpatient treatment. I know we had a few patients that would come in to isolate during COVID, and then we were able to transition them to a treatment center once they were able to be comfortable and off their benzos. And that was really quite rewarding, I think, for everyone. So yeah. Oh, ACEs. See, now I've got the little image to remind me just to talk about ACEs, which would be adverse childhood event screening. I just feel like there's always an opportunity to remind ourselves. And I think you've touched on this so greatly that, substance use disorders are not a moral failing, or, people making bad choices because they're bad people. We've seen time and time again that our patients are incredibly resilient people, incredibly brilliant, passionate, kind, caring people that have had really terrible things happen to them. And so in my clinic, whenever we've spoken with patients about their adverse childhood events, which is a 10-point questionnaire to just talk about bad things that have happened to you as a child, our patients score extremely high. In fact, 10 out of 10 being the most common response for having things like violence in their childhood, neglect, sexual assault, witnessing family members be harmed, and it goes on from there. It's really unpleasant. But what I find when I do talk about these things with my patients is that they're always so grateful that I've taken the time to talk about their life as a whole and to recognize their strength and their resiliency, that they're alive today, and that they're accessing care and getting help, and how we can continue to support them in that. So that's just why I put that there, because I love to take the opportunity to just plug getting to know your patient in whatever way. And if you want to use a tool to do that, the adverse childhood event screening questionnaire is one. So yeah. Uh-oh, Eric has run into further complications. Monty, what's going on?
So while assessing him, it became apparent that admission to hospital is increasingly difficult. Other options for detox need to be determined. What should be done? So I guess he just didn't want to go to the hospital. He just really didn't want to be there.
Or maybe there weren't beds. Like, I've seen this time and time again, right? We're just in such an overloaded system. So yeah. So luckily, yeah, we've taken a moment to highlight things that are available within our province, and certainly there are options in other provinces in terms of different recovery centers, different detox centers, and this list has only expanded, I think, since we originally put this together. The other thing would be, if you're able to keep someone in eMERGE long enough, to really get them to a comfortable place, and then finding a way to transition them home with a plan to support their withdrawal and to support them would also be an option. So yeah. So in this case, he didn't want to go to any of those locations because he was concerned about COVID-19, I think. Hey, he had said, like, oh, I don't really want to go stay where other people are, which was a big thing back then. Perfectly safe to detox at home. So what should we do from here with Eric?
I think that's the next slide. But
then I can talk about Melanie, but because basically what then happened with her was just that, we were really concerned about cirrhosis. We were using a short-acting benzo, as we've already said. We definitely want to use symptom-based management as well, in terms of managing if she's really nauseous and things like that. And if she identifies during her time that she doesn't want to stop drinking, that was when we would have a conversation about MAP, or managed alcohol. And that's something that I was really proud to be able to offer while we could, and is offered in many places, including in the hospital setting in some places, but can be a really great option for someone because ethically, I really struggled with this idea that I was going to support someone with benzos so that they were completely withdrawn off alcohol, knowing that they would return to drink like the following day. So that whole cycle, how could we just support somebody that they could safely just manage their amount of alcohol and not worry about messing around with tolerance and things like that. So yeah, just lots of different options available.
Sorry.
Don't go ahead.
Maybe I can just add a little point here, like, for Melanie, a CWA score would be the better way to go for alcohol withdrawal management as opposed to a structured regimen, just because for a couple of things. I mean, there's a great risk with her cirrhosis that she might have sedation, and so you don't want to sedate her. So like it's better in certain circumstances to sort of stick with the CWA. So that's maybe another fine nuance that I should kind of state.
Yeah, with her being more medically fragile than someone like Eric. Yeah. I'm getting concerned about our number of slides and the time we have here. I'm noticing there's no questions, but please, if you have some, because we're not going to get through all these slides. No humanly way possible will we do that. I'll carry on. But please feel free to ask any questions if you have them.
So, so we can definitely do some home detox potentially with him. So we can see, as Jesse mentioned, whether we can do this. And then I'll pass it over to you for the next case.
Yeah, sorry. And then certainly with Melanie, that CWA guided withdrawal protocol would be great. Restarting meds. Really wasn't interested in talking with an addictions counselor, looking into other options for treatment at this time. And we heard this time again, it broke your heart. I don't think I'll ever be able to stop drinking. I don't even know where to start after all the things that I've been through. And I heard that many times. I had a patient say that he deserved to feel so unwell because he had done so many bad things. And that just kind of broke my heart. Because again, these people have been through a lot. So yeah, let's talk a little bit about the home detox protocol, though. I think that's really interesting.
Yeah, so we've got a new protocol. This is the older protocol for the pandemic, but a newer one. It's just about to come up from AHS. We're on the verge of getting it sent out. It's just going through HS Legal right now, but there is a protocol out there. Next slide.
Does the inclusion criteria change, or is that pretty similar?
Yeah, it's pretty much the same. So, like they have to provide informed consent. This is
like all of it. So this even had like Suboxone and stuff in it, which is not what we're talking about. We're talking about that 1.5 for sure.
For sure. So they have to be stably housed, have someone there available to watch them if there's any concerns. And then the big thing is like looking at their SAQ and PAS score, which we'll talk about in just a second.
Yeah. People that you wouldn't want to be doing. And again, we're just talking about alcohol. Sorry that we have OAT stuff on here. It comes back to that SAQ and PAS score, which we'll just overwhelm you with on the next slide. So I'll let you go ahead and tell us about those.
Yeah, so we've got two scoring tools, and I use both of them. So the PAS score is a validated tool to predict the severity of alcohol withdrawal. It was sort of validated for the inpatient setting. And it was a bunch of odds ratios from a bunch of different studies that kind of amalgamated together in a weighted ratio to determine what the odds ratio would be of having bad outcomes. So if you have 4 or more, you've got a really high odds ratio. I think it's like 160 something or the other. You're going to have a poor consequence. But what they define a poor consequence is very interesting. It could be anything from seizures and severe delirium tremens to feeling agitated and very aggressive. So it's kind of out there. So we use another tool on top of that. Next slide. We use a SAQ. So it's a 20-item clinical screening tool. It was designed to measure the presence and level of alcohol dependence, but it was also used to sort of measure how much medication you could provide to someone. So sort of an indirect tool as to how severe their alcohol withdrawal may be. So next slide.
There they are. In all their glory.
Yeah. Next slide. And you can just Google these and they're available. So if you've got 4 or more on the PAS score, if you've got 30 or more on the SAQ, then we should probably not do a home detox. Next slide.
So here we are with Eric.
He's not doing so hot with his scores. Next slide. So what do we do? Next slide.
Tapering protocol. That's what we do. What does that mean?
So the way we kind of do this is we ask him how many drinks he's drinking on average and try to ask him to be truthful. he has a calendar and he marks down per day how much he's drinking, and he decreases by 1 drink equivalent a day. So the way I kind of tell him to do this is like if he's drinking 26 ounces of vodka, which I think he was on the previous slide, I believe. I'll say go down by 1 ounce a day, measure it out, put it in a shot glass, and you can dilute it with water, but don't dilute it with other alcohol. Don't free pour your alcohol, but mark it down and really try to go slowly. It could be once 1 ounce per day that you can decrease, or 1 ounce every 2 or 3 days that you can decrease. And they tend to do really well with that. Some patients are likely to do the home detox protocol now without much difficulty, some patients likely are able to do a home detox protocol now without much difficulty once they reach that sort of 4 to 5 ounces, I should say, per day.
And how often are you following up with people, Monty? Like, how are you talking to them on the phone? Are you getting them to come in the clinic so you can see how they're doing?
Yeah, a bit of both, and both are very good options. So some people don't want to come to the clinic; they just talk to them over the phone. But I try to get them to come in, and then in terms of making sure they stick to the protocol, that's often very difficult. I find that clients often say that it's really hard for them just to stop. At, like, say they reach 25 ounces, and they're like, "Why can't I do just one more?" And so it becomes a bit difficult for some of them, but we do check with them. So if they're doing if they're coming off of 26 ounces, I'll probably check with them once a week. If they're and I'll have others who might help out, like a peer to help out with the tapering. But outside of that, I might get them to come in sooner if they're very low or they're getting towards the end of their taper.
Cool. You read my mind about do you get like peer or partner support? I feel like that can always be a bit tricky because I don't know if I'm entering into like a potential, not really good thing with a couple, and especially if I'm saying like, well, you need to. So I try to avoid that as best I can. In fact, I try to take, if I see couples together, I try, because often the patient will be like, well, she'll keep an eye on me, she'll make sure I don't, and I try to say, well, it can't just be left up to her, because I can put couples into like really tricky positions. So I don't know how you handle that, but I always find that kind of interesting, and I try to take the pressure off of the partner for sure. So I lied about my panic that we weren't going to get through any of these slides. Now we just have a bunch of slides just talking about the SADQ score, which I don't know if you want to just quickly go through these or not, but it would just be sort of another kind of I guess example of some tapering protocols that you could use if this is something you're wanting to do.
So feel free to screenshot these. Otherwise, they are going to be in the HS protocols.
Yeah, so just looking at the scoring, if it's less than 16, anywhere between 16 and 30, your doses are going to be a little bit higher. And then this is where we really want to be careful, because if they do have a SADQ score over 30, but they have no medical problems, hold on, and no medical problems, or they're over 65. This is, again, really involving community paramedics or someone to keep an eye on people at this point would be ideal if hospitalization or detox in a supervised setting isn't possible. Because you're just getting into a bit of a more risky territory. And so then we talk about what's coming in the future, but just kidding, you've already seen it in sessions 2 and 3 because we had to mess up the order a little bit. I'm really excited that an old classmate of mine had a question in the chat, so I'll pose this to you, Monty. When are you going to start looking for more alcohol related issues such as steatohepatitis, alcoholic cardiomyopathy, esophageal varices? When are you doing that?
I try to do that once they're a bit more stable, that's for sure. And so once they're a bit more comfortable, and once you've sort of developed a therapeutic relationship with them, that's when they kind of dive into it, unless it's very blatantly obvious that there's concerns. If they're like spouting out blood, or if they're really yellow, probably should take care of that right now. So those are the key things that I kind of look at. So if they look more or less okay, kind of take it easy until there's a bit more relationship established. It's kind of a case by case thing.
Great question, though. Not sure if there's any other questions. We're just coming down to the end of our session. I can't believe I was such a pessimist that I thought we weren't going to get through those. Look at me. Who knew? But and please feel free, if you have a question, you can raise your hand and mute, or you can type it in the chat, either under the Q&A or just in the chat is fine. I hadn't been able to see my little square, and it's gotten very dark, and I've gotten very white over the time since we started. But yeah, sorry I didn't have better lighting.
No, that was great. Thanks, guys. Are there any final questions from anyone? Okay, awesome. Yeah, thank you so much for sharing all that knowledge, and it is recorded, so it'll be shared broadly, because I know that was a lot of information and a lot of slides. So I'm sure people might not mind looking at it one more time. I just want to end by pivoting to this commitment to change piece, which is taking a couple of minutes to actually start thinking about what change you might make from what you've heard today, how you might make that change, and then what challenges you might encounter. And you can find the commitment to change form by scanning that little QR code in the bottom right corner, or going to the link, which will be posted in the chat as well. And then I do also want to just end with sharing this fantastic program, My L3 Plan, which is a free online tool that really promotes, again, this self-reflection to identify areas in your practice that you can develop a concrete plan for. And it can be used to meet your practice improvement activities by completing the following cycles. So you've got practice-driven quality improvement activity using objective data, you've got a personal development plan, and then standards of practice quality improvement activity. And fantastic that you can earn up to 24 Main Pro certified credits with that. So with that, we thank you all for being with us tonight, and we appreciate any feedback that you can offer. And if you have a few minutes to complete the evaluation form, we would really appreciate it. And again, thank you so much, Monty and Jessica, for taking the time to go through that with us. I look forward to watching it again, and have a wonderful evening, everybody.